First Five, and some other sources like CDC. They provide self-help materials. They'll mail them a very nice booklet. Tell them what are their local resources in terms of their county. They now have a text reminder program and an app. You gotta have an app. So you do a 30-minute counseling session about your own individual quit plan. They'll have up to 6 follow-up sessions just to see how you're doing around your quit plan. They do have some free nicotine patch offers, and I'll get into the mixed project in a minute, but some of the ones that are ongoing still are from First Five. If you live with a child 5 and under, they'll express mail free nicotine patches to you, and also the Asian Smokers Quit line, which they offer Asian language lines nationally. So a tremendous service, and really, if any takeaway thing from today, it's this. Know that they exist and that they're free, and it's a great resource.
Have you ever considered, or do you know whether they've ever considered also expanding into hypertension counseling? Since they're so related.
Yes, well, so I think they do have fact sheets on other diseases, and so when they do their intake question, they do ask about cardiovascular disease, because if they're going to give free nicotine patches, there are some contraindications. So they do ask about it. I think that's a question for Mary about expanded scope of work for them, though. But maybe a good discussion question. Just wanted to let you know that it's been over 10 years now, but that the California Tobacco Control Program actually has a quit plan for California. And it's not so much focused on the individual provider doing more. It's saying, how do we use this population-based resource for everybody? So integrating not just with the individual provider, but with social services, behavioral health, employers, this idea of changing how we do cessation, not just at the individual level, but supporting the whole population. Okay, that was just a brief overview of tobacco cessation treatment. That could be a whole hour in itself. Let me switch gears to California Quits and how we came about over the past 5-6 years or so. So what is California Quits? We are a new statewide project to accelerate health system integration of tobacco treatment. A key part of this, as I mentioned, is with connecting with the California Smokers Helpline, more than just passing out that gold card like I used to do in med school. And then also collaborating across providers, plans, and public health partners, all of whom are trying to help the same individual. And yet a lot of us don't know the others in the room. So there have been a lot of health systems changes that have made this even possible to prioritize tobacco. As a lot of you know, sitting in the room who are providers, we've had the benefit and curse of electronic medical records. In some ways it makes our life easier, in some ways we're still struggling with a lot of things, can't get IT to do this or that. But one of the things that we've had to do is we've had to start assessing tobacco status as a meaningful use measure. So that has enabled us to start tracking our data and start thinking about quality metrics, which we are now all moving towards. On the health plan side, with Medicaid, as Dr. Kohatsu mentioned, so Medi-Cal had this enormous, as you guys all may know, had this enormous growth with expansion, such that it is now 1 in 3 Californians. Medi-Cal now covers 1 in 3 Californians. And when CMS was doing this and all the Affordable Care Act was doing this, they recognized we need to emphasize prevention, and so therefore tobacco treatment became a priority as well in terms of covering medication and counseling and so forth. I just also want to acknowledge that Joanne Wellman, who is taking a sip of water here in the room, Joanne, if you can wave. For years I've been hearing the billing codes for providers to do counseling are not turned on, no one can charge for it, and Joanne, when she worked at Department of Healthcare Services, asked enough questions and got it turned on. So we can actually now in California, and Joanne, I know you're just kind of like, I was just doing my job, but no, really, that means, I think being here in Sacramento, you asked the right questions and you were persistent, and it helped a whole bunch of us. Okay, so UC Quits and the Mixed Project, okay, together they kind of have transformed what is now California Quits. So UC Quits was something that when I was at UC Davis, the helpline folks called me up and said, hey, we've got some CDC money to start an e-referral to the helpline. I'm like, I'm not sure what an e-referral is. But really, this was something that kind of changed how we started doing tobacco treatment. And then UC Health decided this was a good enough project that we could scale it up across the 5 UCs. And then as we've done all these electronic medical record modifications, we've been now kind of moving towards quality metrics and how do we do a better job in sharing what we're doing. And everyone's adapted it to some extent to their own culture or institution, but this has been a tremendous sharing experience. For MIX, the Medi-Cal Incentives to Quit Smoking Project, as Dr. Kohatsu mentioned, a $10 million, I guess you could call it like a demonstration project about how can incentives change behavior for those socioeconomic folks. Because there's actually a lot of randomized trials demonstrating that if you use incentives, it can help with short-term behavior change. Something like picking up the phone and calling the helpline, as opposed to, well, now you're going to quit forever and ever, and then we'll give you an incentive. So this is asking them to make one small behavior change. And what we were promoting in this project at first was ask and earn a $20 gift card if you complete the counseling. And then we were also, later on, we kind of rolled out free nicotine patches that were offered to callers too. And this was all verified with if they were Medi-Cal eligible with their ID card. So let me back up again to UC Quits. What is this e-referral? What happens when you use this e-referral to a helpline? And this is going on nationwide. We're not the only state doing this. The beauty of having this e-referral connection is that here at UC Davis, if I put in the order for the helpline to call a patient, that information gets pushed over to the helpline. The helpline will call back my patient and send me back a results message into my inbox, like a lab result. Well, so it was kind of, mind-blowing that, wow, I can actually have someone call my patient and get help. And there was a randomized trial that was published in JAMA Internal Medicine a few years ago that they wanted to see if you compare that Ask Advise Connect versus the usual Ask Advise Refer, like passing out the little card and telling a patient, go do it yourself. That you're actually 13 times more likely to have that patient connect to the quit line. So again, it's just one of those easier things to reduce, easy things to do to reduce access barriers when you're asking someone to make a major change in their life that they don't maybe or may not really want to, but it's a service delivery. And it doesn't matter who you are or what insurance coverage you have.
So Elisa, since we have many different health systems in the room, can you just elaborate further on, okay, here's how you customize your EHR, and here's how it works?
Yes, so there are 3 different ways to do that, and I think I might address it later on. They have a free web-based referral portal, which it's good for maybe like our free student-run clinics, maybe who don't have IT to fix their EMR. There's another way of called Direct, which is secure email with an outside entity, which my understanding is most EHRs should have that capacity to talk to an external organization. This is the top-of-the-line model where it's fully integrated into your IT system. So the helpline folks were set up to, our California Quits team can help facilitate that to figure out which is the best system for you.
So for instance, if Travis Air Force Base wanted to get help getting their system to do this, if in fact they aren't already doing it, but just for example, how would that work? Dr. Skye would call you?
Yes. Well, we can figure out, we can triage and help and connect with the helpline to see, do you have something already? What is it going to involve? Is there a cost involved? And so we can share also if other systems with the same EHR already have something up and running.
So how many of you have this in your EHRs? Raise of hands.
Okay. Yes. And so this may be something also we'll talk with One Community Health, because we've been talking a lot the past week.
Maybe we should find out what healthcare delivery systems are here. Sutter, Neal, UC.
I don't think we have a very full agenda,
Well, you
so
just asked that question.
I'm sorry I'm interrupting your talk, but let's do that in that last half hour.
Yes.
Everybody queue up your questions for getting technical assistance.
Right. Exactly.
Yes. Okay. Okay, one more final thing about UC Quiz. Just we had also done this educational push too, which we're dusting off for California Quiz. We had offered free CMEs, and we're going to refresh this and boot it back up. There are YouTube videos that are like 15 minutes long. They're meant a little bit more for the resident student learner folks, but we know that there were a lot of providers who actually utilized this when we made it free for everyone. So more to come on this in the upcoming year. Okay, transitioning back to mix and a little bit.
Can I ask one other question, because I was just being asked that I didn't know about. So the quick line has text capability, I believe.
Text reminder
But
with
does
an option to
text
chat.
first before the first call? I didn't believe so. Can you clarify?
Yeah, so this is something we're actually working with LA County now, trying to figure out how to do this. You have to have text permission first, which is a whole other legal issue to overcome, but what I've done in clinic for someone who didn't want to talk to someone on the telephone, because not a lot of people do anymore, was I just entered in their information into the text program, and I've worked it out with them to say if I put it into the e-referral in the comments section, like text only, doesn't want to talk to somebody, you know, we're trying to figure out how to just enroll them in their text reminder program.
I think the main problem is people don't answer a phone call. You get a text first to say, I am the smoking cessation people. I'll be calling you in 5 minutes. Please answer the phone. And more likely to answer.
It is a big problem nationwide that everyone's trying to figure out how to. Right now, for the UCs, it's about a 50% pickup rate, contact rate. And that's not even, you know, did you refuse or agree to service? It's just who picks up the phone to a 1-800 number. So this is something that everyone is interested in and we're working on.
In scheduling a call would be the other thing. So if you could say they're going to be calling you at 10 p.m. tomorrow, 10 a.m. tomorrow.
Right. Yeah, so in our e-referral, there is what is the best time to call. I mean, so if you open the order, you could put in some of those things, or like what language to call back in. And, you know, we're also trying to roll out a paper that says, this is the phone number that's going to call you back, because, you know, so many scams are now calling all of us. Yeah. Okay, so mix, which is, again, this is just touching the surface of what mix is, but I was the person here at Sacramento helping coordinate a lot of the statewide outreach. Just want to let you know that, it was a very successful program in that we increased the helpline's usual annual call case count up to 70% increase from the prior years, and they'd already been working a lot to get providers on board and a lot of public awareness. And in case you're kind of skeptically thinking like, oh, people are just calling, actually, you know, over 2/3 of them completed counseling. You know, recognizing also that some of the folks are calling may also be calling for help for one of their friends or family. They will also help someone. That's called a proxy way of helping too. In terms of incentives, you know, when I first started this as a clinician, I had no idea what to expect because I don't usually offer $20 to somebody to do behavior change. And we were promoting this through health channels. This was not something we went through publicly through the media. We gave this to providers. We gave these postcards to providers and mailed it out to over 1,000 clinics. We worked with the California Primary Care Association, their address list, did a webinar, pushed it all out. We also worked with Tribal Health, and Jackie Caslow in the room, Jackie wave, was a huge part of making that happen too. And then the health plans also, we were leveraging Medi-Cal's, one of their main benefit mailing education programs called JVR, which is a quarterly mailing. So we got that in there too. So that was another important channel for outreach. And then some of the Medi-Cal managed care plans started doing it themselves, and I'll show you a little bit of data. So about 12% of folks asked for the $20 incentive that was promoted through health channels, and we know there were certain subgroups that responded, and maybe because of some of this outreach. as well. In Sacramento here, we had our African-American consultant, I don't see her here, but Twyla Laster was an important partner in helping us reach out to the community. And then in terms of the nicotine patches, when it was available, about almost 3/4 of folks who called got nicotine patches. And this is not something that you had to ask and earn. This was something that the helpline counselor just offered to them, saying, would you like to have nicotine patches since you're a Medi-Cal eligible member? Bottom line for some of this outreach, we actually doubled the reach. It's really hard to move the reach of a program. And usually, population-wise, utilization of a quit line is like 1% nationwide. And in California, it was already pretty high at 2%. And then through a lot of these efforts, especially that large mass mailing when we had the Medicaid expansion, we got up to 4.5% of reaching California's Medicaid smokers. So that's actually pretty impressive results. And then you see for the non-Medi-Cal side in that table, it didn't really budge. And then in terms of referral source, one of the quit lines questions is, where did you hear about us? You can see on the green, which is Medi-Cal, that there were more folks who said, I heard this from my provider or my health plan, as opposed to the traditional, very expensive route of media. Just wanted to show some Sacramento County data because we piloted this in Sacramento County first. And so you'll see that there are some surges depending on what we were doing, but even from the get-go, because we had this initial promotion before even the summer rollout, you'll see that that's why Sacramento was leading. So that blue bar is Medi-Cal calls, and then the pink bars are, pink part of the bar is not Medi-Cal. So just wanted to put a real number to it, but there were 7,000 Medi-Cal calls in Sacramento County. And then what can health plans do? I mentioned like how using the mailing channels that health plans have is really tremendous, and Kaiser here was amazing because they were the first to show that this could be done. So this is Kaiser's flyer where they adapted our materials for their members because it had to say Kaiser on it. And when they mailed it out to their internal list of smokers, we saw for folks who said, I have Kaiser, we saw a boost in calls around the time of the mailing. It's usually about 1 month later. And then as other health plans were able to learn of this and see some of these results, Molina Healthcare was another one that did this, and they did it a lot at the end too. So that's why you see around the end of on the right-hand side, you see a lot more calls from Molina once there was this push promotion. And the helpline can track these if we put a tracking code on these materials, which I have now learned. Okay, system examples, and this will be a nice segue into our next session. And I will try to go a little bit faster so we can have more time for discussion. So California Quits, it's not just asking the docs to do more. I'm a doc, I don't want to, I feel, and I hear a lot from primary care, we're already doing a lot. We have so many competing priorities, but how do we do this better and together? So how do we get providers, plans, and public health partners all to work together and use the same resources and leverage each other's efforts? And our role in California Quits is to help facilitate these partnerships. Just a little bit about our 5-year scope of work, and this is more for this is more state speak, but we're trying to reach safety net healthcare systems and also Medi-Cal managed care plans, kind of these work groups, collaborative learning and sharing, and also technical assistance. We have some resources to help folks too. Just to say that we are the Tobacco Learning Collaborative for the state for one of the Department of Healthcare Services' big quality improvement programs. So UC Davis, we've elected one of the programs as Million Hearts for our quality improvement program. And this is for the safety net hospitals, clinics, to do quality improvement and redesign and how do we deliver care. This is over 5 years. And some of you in the room may know this was called DISRIC before. And so PRIME is a little bit better as an acronym than DISRIC. But just so you know, so the 17 designated public hospitals are the ones in blue, and those are those blue dots. And now PRIME has expanded to smaller, more regional hospitals, and that's they cover the orange counties in that map. So those folks are a little bit behind than what the bigger public hospitals like the UCs have been doing already for several years, but it's all shared learning. You know, in learning collaboratives, there's sometimes folks who are more advanced who help the ones who are just starting. And just so you know, that counseling quality metric, it's something that is from the National Quality Forum. And I was really excited, actually, I think April Raisler at the State Tobacco Program pointed out to me that CMS, Medicare and Medicaid Services, is now saying if you're going to report your quality metrics electronically, we're going to start asking you to break out your smokers and see how you're helping them. And that's where all value-based care is heading towards. So all the more reason not to rest on our laurels if our quality metrics are looking good. You actually have to start helping your smokers too. This is just a little bit more about how we address the tobacco quality metric, and just want to emphasize the non-smokers should be assessed too. Even though all these quality metrics focus on adults, we know that family medicine and pediatrics and OB/GYN also deal with the pediatric population as well, and there is no safe level of exposure for tobacco. Okay, just an example of collaborative sharing. This was a picture of us at the helpline in our pilot year. This is UC San Diego talking about how their vision, Dr. Siddipati, she has this vision for how are we going to move towards 1.0 of just the doc pushing a button and saying, I'm calling for help for you, to eventually population health. And we had a nice group, not just the 5 UCs, but we also had Kern, Los Angeles Department of Health Services, and also Alameda. We all presented and shared what we were doing. This was also made into a free webinar at the helpline where they featured Alameda and also LA. And Alameda is actually, they've actually demonstrated that their medical assistants helping with this referral actually gets way higher numbers than waiting for the doc to do it. And that's not rocket science, but you know, it just demonstrated to me, you know, this is one of the promising models of how we should do things. Hattie, I mentioned how does somebody get started. This is one of the fact sheets we have about the different choices of connecting to the helpline and pros and cons of it, and cost issues, but really we can help facilitate a lot of this.
Can I just ask you about the web-based?
Oh, yes.
So that's free.
Yes.
So everyone in this room can afford it.
Yes.
So
you just have to register.
Tell us more about it. So you are a solo doc, for instance.
Yes.
And you want your doctors to have access. So how would they use it?
So you just sign up. It's on the website for nobuts.org, and it's /referral. You just register one time, and then from then on, it's all verbal consent. You don't have to have your patient sign anything, which is a big hassle. Once you're registered, you can go into that portal anytime, say, drop-down menu, this is me, and just click on the verbal consent. I talk to somebody, it's okay to have you call them. Very simple.
Can non-physicians do it?
Yes.
Anybody can do it?
Yes. As long as you're registered in their system, and there's a person on the other end. So it's great, but at the same time, it sounds wonderful, but at the same time, it's not. Since you have to go outside to this portal, it's not totally integrated. And it's not as nice as the e-referral where I get this message back. It's built into my EHR. I have to physically go into the internet and type in nobuts.org/referral.
Can our churches do that approach?
Yes. Yes. That's good. Yeah. It doesn't have to be done. Tobacco treatment doesn't have to be a doctor. Okay, I see your eyes are lighting up. Okay, well, we got to. Okay, so I'm pushing for the e-referral because UC Irvine, Jamie Anand, one of their nurse QI folks, just asked me one day, we went to all this trouble for building the e-referral. Can we use this for a meaningful use reporting to a registry? And I said, I'm not sure. And then we kept asking, and lo and behold, we're the first state to have our e-referral counted as a public health registry. So this is like immunizations, this is like the cancer registry. So right now it's just a billboard to say, hey, there's something you can report to called the California Smokers Helpline and learn more about it. But really, we have the potential for doing a lot more population health together. I mean, think about re-engagement. If the smoker helpline calls back the person you referred before and tells you about it, or the health plans can figure out who got medications and did they get billed properly. there's a lot of potential, and we're just starting to figure out more. I don't know if there's pharmacists in the room, but this is another, I just wanted to throw out another system example, that California pharmacists are actually able to furnish nicotine medication without a provider prescription. One of our systems, Cahuilla Delta in Tulare County, there's actually a pharmacist who's creating a telephone-based program so then she can also furnish the medications, offload the docs. There's a VA-based model that demonstrates how to do this, and she's working with UCSF pharmacies, students also to help her. So again, another system model that addresses some of those barriers of that the doc's not doing enough or can't get to this enough. Just want to do a shout out to our, because we're talking about specialty care also with cardiology, the cancer centers are just starting to address tobacco nationwide. So UC Davis, we're one of the first cancer centers on the West Coast to participate in this NCI cessation initiative funded by the Moonshot. I don't know if you know the Bo Biden Moonshot funding, but this is a huge culture shift for cancer, where as a med student, I was told, oh, they've got cancer, let them smoke. Now we know better. Now we know better that this actually, if you quit now, it improves your chances of better outcomes for surgery, radiation, chemo. So this has been a tremendous project that Terry, if you want to wave hi, she's our nurse project manager for it. She has just been running with this. It's been amazing. And our MAs weren't even assessing tobacco, which was a little bit of an embarrassment, but now they are doing it. And we're actually tasked by NCI to follow up for folks who engaged in the tobacco program, did they quit or not? And I know that's what Neal wants to also ask everyone. That we need to close the loop, you know, not just say call and hope, you know, good luck, but we need to do that follow-up. And the next steps that we're doing is trying to incorporate some of these population-based approaches that we've already seen, like the MA referrals, and then starting to do some population messaging already with the identified smokers that we have. Just wanted to give a shout out also to future plans. There's a lot of affinity groups that we'd love to try to address, including maternal infant health, tribal health. If you were thinking about behavioral health and oral health, and I know Debbie from Oral Health is here today, which is very important for cardiovascular. Debbie, you want to give a wave? You know, our new tobacco tax Prop 56 funding has funded oral health. And so they are prioritizing tobacco treatment as well. UCSF is helping with a lot of those priority populations too. Okay, just to wrap up a few more things. I don't know if there's any health plans in the room. Yes? Oh, where are you from?
HealthNet.
Oh yes, hi Martha. So there is a Medi-Cal all-plan letter, thanks to Neal and also Joanne for working on this, that incorporates guidance on what health plans should be doing in terms of population health and tobacco treatment. So just wanted to this is a lot of stuff on here, but just want to let you know that this is codified out there. And how do we help the plans achieve some of this? You know, now that mix is over with all the incentives, we wanted to start re-engaging with the health plans and say, you know who your smokers are, let's start messaging out to them to remind them to engage. So we just did a mailing last fall with Molina, where we sent things out to, this mailing out to 4,000 COPD smokers and 7,000 smokers with diabetes. No incentive message, but still, you know, there's a health education message. The response was actually pretty low, but not unexpected, because there are no incentives on this. How do we get incentives back onto here, whether it's nicotine patches, you know, something that creates the urgency of you need to call and do something for your health, and whether or not there are gift cards, incentives, that may be something we need to discuss further. Also public health, okay, finally, public health partners in the room. Danica, I know you're here somewhere. Okay, so Danica is from our Sacramento County Tobacco Education Program. Every county is funded by the California Tobacco Control Program on usually, you know, policy objectives. The school districts are involved, and at the table. Here in Sacramento, we have the cessation objective, and part of this is to help clinics and other folks in the region to implement an Ask Advise Refer protocol. And also, just so you know, the county is also responsible for updating the list of available classes in the region. So one time I had a patient who said, I only want to do acupuncture, don't talk to me about anything else. And I found an acupuncturist on their county list. And the patient walked away very happily. So just know that there are resources our county can provide.